Welcome to the broadcast. You're listening to Knife After Death with Dr. Darin Wolfe.
Say, did you ever hear the saxophone let out an awful moan, let out an awful groan? It makes you feel so nervous, yet it's great.
Yes, welcome back to Knife After Death. This is going to be technically the second episode of the mythical fourth season. And I want to thank everyone for coming back and listening and watching. We have it over at YouTube as well. And I want to just first talk about anything from last episode. We encourage questions, we encourage comments, and I have to say there aren't any except positive things. And that's not to say that we're perfect and awesome, although maybe we are. But I don't have anything to say except, everybody was very excited to have it back. And I'm excited, and I think Jessie's excited. And it turned out to be a really good episode. I think that everyone seemed to like it a lot. So we said, what the heck, let's just do it again this week. And we hope to do that for the rest of the year. Now, today, first of all, let me say that the first part of each episode, I kind of want to go over if there are any things that we misspoke on, anything that people had questions on, and apparently we have not been alerted to any of those things. So there's really not much to say there. I do want to mention the socials up front. So this podcast, if you're listening, it's also at my YouTube, which is called Knife After Death, and you can watch us. You can see us talking, and you can see Jessie from the Shadow Realm. She lives in a place that's only black and white, and I live in the color. Yes, I live in the color realm, and I'm here in my library. And there's all sorts of interesting stuff in here. So yeah, that's where you can see the podcast, and then of course. My TikTok is called The Dead Letter, same as the Instagram. And then, Jessie, you have some news about the Instagram situation.
Yes, so we have, and I actually updated it. I'll keep it in the show notes. And then you can find it on both of our profiles. But we have a show specific Instagram account now, and you're welcome to message us there. I keep up on it. We also have for questions for you to submit that are more in depth. I've got two, by the way. So what we said last time wasn't totally true. We have two questions so far that were really, really amazing. I'm excited about that. But yeah, just don't be shy. Just you can inundate that. I made that email account specifically to be inundated. And then you can always definitely message the show's Instagram. Both of those will be linked in the show notes. And then just to kind of give you an incentive, I am working right now on stickers for our, it'll be just like a little sticker of our logo. And the first 10 questions, and I already have two that get submitted to either the email, preferably the email, just so I can keep track of it better, or the podcast will get free stickers. So just send me your email.
Who doesn't love stickers? Exactly.
You can put them on a awesome. Yeti. You can put them on a suspect flask.
Yeah, you can stick them on your face if you want. I suspect that as we continue to do more of these episodes, that's going to be a more robust portion of the show. And the idea is that we're trying to put together some Q&A episodes that people like to just have kind of random questions for us and our various areas of study and work. So we'll be hitting those. But let's go ahead and maybe start the show, the actual topic for today. This is a really cool topic, and this one was actually suggested by Jessie, and it's a topic that I have done a few videos on over the course of my, online pathology career. And this is commonly referred to as the broken heart syndrome, or more specifically or more formally, Takotsubo cardiomyopathy. And so, everybody's kind of heard of this sort of thing, somebody dying after, a tragic thing happening. I remember growing up in southern Indiana, in rural southern Indiana, and it was not an uncommon thing to have like an older person who would die after a long illness, or maybe they were just of old age, and then their spouse would very often, die sometime very shortly thereafter. Sometimes it was days, or sometimes it would be weeks, maybe a couple of months. And I always remember people saying, they would say, this is like 30, 40 years ago. I remember people saying, well, they died of a broken heart. And that's kind of a sweet thing to say, it's kind of poetic because they've lost their, lifelong love, or perhaps it was a family member. It could be, mother, daughter, son, things like that. And but as it turns out, it's a very real thing. It is a very real thing. And so we are going to talk about this today. We're going to go over kind of the some definitions, some etymology, some symptoms, talk a little bit about how it might be worked up, and then we'll kind of hit the stuff that I actually do, which is autopsy. Um, and so I kind of thought that, well, and first of all, definition wise, this is considered a temporary condition if you survive it, a temporary condition of what is essentially kind of an acute heart failure. Basically, there is a weakening of the heart after a stressful event. And that weakening then produces the symptoms that we know as broken heart syndrome or Takotsubo cardiomyopathy. And I think, Jesse, I think we wanted to talk a little bit up front about the actual name, the etymology. And so I was thinking you could do the Takotsubo portion, and then I would talk about cardiomyopathy.
Perfect. Okay. So the Takotsubo portion, it's actually like many things in medicine are either named after the person that discovered them or after objects they look like on occasion. This one is named after an octopus trap originating in Japan. Give me a second.
I heard they catch crabs in that trap too.
Alrighty. Tell me
So
what
right
you're
now,
seeing.
Jessie is sharing her screen. Yes.
Alrighty. So I'm sharing the screen here, and you can kind of see what they've, I loved this one because it does show you what the left ventricle looks like when it is not in this state of what they call ballooning or inflammation. So you have the normal heart on the on the left hand side. Is it the left hand side on yours as well?
Yeah.
Okay, just making sure.
It is left. And I also want to tell, yes, it is left. And I also want to tell people who are listening that if you want to see these images, you can go to the YouTube and watch our podcast and you can actually see these images. But I think Jesse's going to go ahead and put these on the Instagram account,
Yes,
so
yes.
that you can go there and have a look at those. And in short, what it's showing is it's showing the ventricle both in the normal state and in this state of cardiomyopathy. And it's showing the actual what an octopus trap looks like. And I know that if you're driving in your car, you're cleaning your house, you're going for a walk, it sort of looks almost like a basket shape. And then somehow, I'm not an octopus fisherman, so I don't know how that works, but it kind of gets trapped in there and it's kind of a balloon shaped object.
And it looks like there's like a string or a rope around like the opening so that they can cinch it. And that's kind of
Yeah.
what ends up the heart, the left ventricle ends up looking like as well, kind of like it's like tightened almost at the top a little bit.
Yeah. Yeah. What happens is it balloons out in a portion, and then another portion becomes hyperkinetic or very tense.
Mhm.
And so it produces this balloon effect. And a very cool image there. Did you want to show another one at this point?
Sure. Were you interested in talking about, let me just do the radiograph here.
Yeah, so now
That's
she's got an image which I think is a fluoroscopy, which is kind of like
Yeah.
a real-time X-ray that they used to do, and sometimes they still do it on things. But
And this one's real. Like
it's
this
kind of
yeah.
yeah. Is this a video or is this just
This one is
an
not the
image?
video. The video that I have, let me take it down. This video I wanted to show because this one is biventricular.
Oh, she's bringing out the big guns with the
You can see
biventricular.
that.
Yeah, so I'm going to describe this for the people listening. So what Jesse's put up on the screen, and I encourage you to go look at these at our social media, but you can basically see the motion of the left ventricle as it beats, and toward the apex or the tip of the heart, that means the part that goes to the left side of the body and is at the bottom in most people, it's ballooned out in that area, and you can actually see it really well in this video.
Yeah, I really liked this one.
And so that's where we get into the cardiomyopathy portion, which I'm going to talk about. First of all, I wanted to say that I did some studying on how long this has been described, and the reason why is because I have a book that is specifically for heart ailment pathology. It's called Sudden Death in Forensic Medicine or Sudden Cardiac Death in Forensic Medicine, and that book was published in about 2006 or so. And I immediately went to that book because I thought, oh, there are going to be all kinds of great stuff on Takotsubo cardiomyopathy. And guess what? There wasn't a single entry in there. So I had to go elsewhere for the information because this is not that common of a thing. But I thought, gosh, how recent is this? And what I found actually was that a Japanese doctor named Dr. Sato described this formally in 1990 or 1991. So it had been described, but for whatever reason, it wasn't in the book that I looked at. And one element I thought was pretty interesting about the fact that this is Takotsubo, it's clearly a Japanese word, is that there are a number of Japanese eponyms for cardiac disease. I don't know why that is. I don't have an explanation, but there's a disease called Kawasaki disease, which tends to occur in children. There's another disease called Takayasu's arteritis, which occurs, which is an inflammation of the arteries. So I kind of found it interesting that, for whatever reason, the Japanese have a little bit of the market share on naming cardiac diseases. But I wanted to talk about this cardiomyopathy because we have to remember that, yes, there are doctors that watch this and listen to this show, and there are nurses and there are healthcare people who have a lot of background, but there's a lot of people who don't have a medicine and science background. So I love etymology, which is the study of words, how the words are formed. So cardiomyopathy, if you break it down, cardio, of course, very easily means heart. Myo means muscle, and apathy or pathy means disease. So this is a disease of the heart muscle. It's specifically of the muscle, not of the valves, not of the coronary arteries. And that's why when you have this weakening, you're going to have inefficient beating of the heart. If you are inefficiently beating, the heart is beating, it's not getting blood to where it needs to go. And that's where you start getting into the symptoms for this disease. And then, Jesse, did you have, and I'm going to talk a little bit more about the physiology because it's very interesting, but did you have any statistics on how common this is or what scenarios these might occur?
You know,
Was it about 80%?
it's about 80%. And then weirdly enough, like I not to get too in depth with myself personally, but I have it right now, which is one of the reasons I suggested it. And I should have chimed in a little earlier when you were talking about like, it being a temporary condition and it, my prognosis is very good. However, as somebody that just wants to get back to their life like in a normal way, having 4 weeks to 6 months is kind of an intense, like a cable guy time frame. And it's not, I didn't like the 6 months thing. I'm just like, ooh, that's a long time. But
Yeah.
I run every day right now. I walk very briskly because I'm trying not to like aggravate it too much. But
Yeah.
and then
Yeah.
I've
So
had patience
Jesse,
with it.
yeah, so she suggested this because she's actually experiencing this right now, and thankfully she's doing well and she's talking to us here. And I'll talk more about statistics in terms of mortality a little bit later and kind of like how that works. But I did say temporary, and temporary is a very vague word, right? Temporary
Yes.
can mean a couple of minutes or a day, but temporary can mean many months. And that's the case with individuals who have this. If you have it and you're doing fine, you're surviving, you don't have any other underlying medical conditions, you're going to do pretty well with it. But there are sequelae, or there are symptoms and syndromes that can continue once someone has it and they are healing from it. They are trying to get better. Um, you know, Folks can develop arrhythmias. They can develop such as atrial fibrillation. You can have, because the heart is beating inefficiently, you can also have blood clots. And I'm not trying to scare you, Jesse. I'm sure you already know all this, but I just want to make sure our
Good things to
listeners and
be,
watchers understand.
yeah, good things to be aware of though,
Yeah,
because,
right.
yeah, there's just any comorbidity. I'm fortunate in the sense that I don't have any. I mean, but I do have, heart issues in the family. So obviously, like me
Yeah,
babying it like a little bit and just trying really hard to like adhere to instructions from a physician is important to me.
yeah.
But yeah, like, and I've had a patient diagnosed with it, and it was very frustrating for me because the physician that I was working with at the time did not believe her. So
Yeah.
she had gone through the loss of a child. Um,
Mm,
and, she herself was very, socioeconomically not doing very well on top of
mm,
this event. So, I mean, just nothing but stress. She did have a lot of comorbidities. She was deaf, she had type 2 diabetes. So her prognosis, especially like when you're reading the ER report, was a little different than what the discussion with my physician was. But yeah, it's just you gotta listen. And even if it's something,
well, exactly.
yeah,
And that's
if
part of why
it's,
we're talking about it. Yeah,
yeah.
that's part of why we're talking
Mhm.
about it, is to bring a little more awareness to it. Because when I was reading about this disease in my research before this podcast, I was reading about how it's underdiagnosed. And I think it is because when we learn medicine, a lot of the times we are trained to have more of a corporeal understanding, more of a physical understanding. And since this is a disease which starts typically with an emotional basis, I think it is disregarded. It is much more common in women. In fact, something like 80 to 90% of these cases occur in women. And I get told a lot online that from women, folks who follow me, that they have not been taken seriously by their doctor, particularly if that doctor is a male. And so I listen to that and I understand that. As a pathologist, I always think about the worst case scenario first. Like I would be thinking about this if somebody had a stressor. I would immediately start thinking about this. I think cardiologists probably also think a little bit more about this, but doctors who are not thinking about an emotional stressor causing a physical illness may skip over this and try to attribute it to something else. So, I think, and that's part of why we're doing this podcast, is so that people can think about this not just for themselves, because people listening to this, they may have an issue that has caused great emotional stress, or maybe it happens in the future. Maybe it happens in the next few months or years. They can think about that if they're starting to have symptoms. Hey, I better go get this checked out because this could be something more than just emotional stress. And on the healthcare side, we have lots of healthcare workers who listen to this. I want you to think about it if you have a patient who comes in with that history. And from that part, Jesse, if you don't have anything else to add there,
um
are you good?
no, other than just like you said, just listening to patients. And something you actually said in the very beginning of the episode too, we're always going to see something new. That's one of the reasons it's, exciting to work in medicine, is because there's always going to be something that you haven't seen before. And that's my favorite thing, I think, about pathology. Like, you might have a boring
Yeah,
week, like boring couple weeks, and then like you'll see something that you have not seen yet. But I mean, I think it's always just important to kind of think about those things. Like, you may not be the person to discover something within medicine or pathology, but you might be one of like the first like groups of people that see it for the first time. So kind of like the same way that
exactly.
a
And
asepsis hand technique used to be considered like a quack thing. And now it's standard precaution.
Standard of care, exactly. Yeah, and just to touch on that really quickly, I had talked about the Japanese doctor who had described this disease in a research paper, but as I continued to look through some of my research for this podcast, this phenomenon had been described for a while, since like the 60s or 70s. It just hadn't been formally named, really, but it was basically dealing with heart trouble after an emotional stressor. Um, and there was even a name for this, and it's called catecholamine cardiomyopathy or catecholamine toxicity. And that's where I want to talk about the mechanism for this disease. First of all, I want to say that the mechanism is not extremely well understood. Compare this to, say, diabetes. We understand that issues with insulin not working or not having it at all results in high blood sugar, therefore causing the symptoms of diabetes. In this case, the way that this disease works is more theoretical, and one of the ways is catecholamine toxicity. And so, what does that mean? Well, first of all, what catecholamines are kind of like stress hormones that occur when we are feeling great excitement, whether that be fear or whether that be something happy that's occurred, or the classic is when you think about fight or flight. When and the example they always give in a physiology class is you're in the woods and a bear is chasing you. Your adrenal glands, specifically the medulla, the central part of the adrenal glands, pump out tons of epinephrine and norepinephrine. And what that does is it increases your heart rate, it increases the blood flow to muscles, it increases your breathing rate, and therefore it sets you up for being able to get away from something really bad. Here's the problem. When you have a ton of catecholamines and stress hormones, that can cause issues with your heart. And that's where the catecholamine toxicity comes in. The theory is that your body pumps this gigantic amount out into the blood, and it actually stuns the myocardium, the heart muscle itself. It stuns a portion of the muscle, which in the case of the Takotsubo cardiomyopathy results in that ballooning, because you've got part that's stunned and you've got part that's still trying to work, and it's just not very efficient. Now, I have seen this before. I have not in Takotsubo, not in this particular disorder, but in a disorder, a tumor actually, called pheochromocytoma. And this is a tumor of the adrenal gland, specifically the medulla of the adrenal gland, that as part of its nature produces large amounts of catecholamines into the blood. They're actually, when you test for it, you usually test for it in the urine. But I had a lady who, and I'm kind of getting a little bit of a tangent, but I want to show how catecholamine toxicity works. There was this lady who was doing, well, she was like 40, and she had a little bit of hypertension, a little bit of anxiety, and she goes out to eat with her friends. I think she's on a work trip or something, and she starts to not feel very well. And now, meanwhile, they think maybe it's food poisoning. She says, "I'm going to go back to the hotel." She goes back to the hotel, and then she goes down. She actually collapses. They call 911. They get her to the ER. They start working her. She codes. They're trying to bring her. They're trying to get her some care. She codes. She goes to code blue, completely cardiorespiratory arrest. They get her back. She goes code blue again. She dies. Well, during that code blue, they were able to get a CT scan of the abdomen, and what they found was a tumor in the adrenal gland. This lady had a pheochromocytoma that she did not know about. This is what caused her anxiety. This is what caused her hypertension. And ultimately, this is what caused her death.
Wow.
Because it poured out so much of that stuff. Yeah, exactly. It poured out so much of that stuff. It stunned her heart and caused her to go into cardiorespiratory arrest. So this is the one of the mechanisms they've talked about for this disease, and it makes sense if you think about it. Whether you're just so devastated that something has happened, someone's died, you've lost a job, relationship end, something like that, and some people handle it differently than others biochemically, and that's why this disease can pop up.
Yeah, I've certainly
Let's
noticed,
see
I mean,
what
when I
else.
was
Yeah.
very first, according to my physician and then cardiologist, um, I probably had it earlier than even when I noticed. But the main time that I would notice it, I was
Mhm.
starting to get like a little short of breath. Chest pain happened like right after the event. But then I would fall asleep at night and like I'm not aware of my heart normally. It's just there, it's beating, it's doing what it's supposed to. But
Mhm.
as I was falling asleep was when I was stillest, I could feel it doing just something that I would describe as weird. So that's kind
Like
of
a
when I,
palpitation.
yeah, yeah. And that's kind of when I went, okay, maybe I just need to go. And, that's actually fortunately for me because I'd had that patient with that experience. Um, I had enough of a background, especially after with what I had just gone through. I was like, it's likely. So I just, went to go have it
Yeah.
looked at, and that's what it ended up being. So
Well, I'm glad you actually jumped to that. That was a perfect segue that we did not plan, but I wanted to talk about symptoms next. And what you had described is pretty typical.
mhm.
Um, Chest pain, shortness of breath, palpitations, and even fainting. We call that syncope.
Yeah.
Um, so the issue here is that those symptoms are also the same for a heart attack.
Yes.
Those symptoms can also be the same for something like a pulmonary embolism. So exactly. So people will present with heart attack-like symptoms, and then you do the ultrasound, you do the EKG, you do the cardiac enzymes, and it comes out that this is what they have. A statistic I found, which I believe was from, I'm not sure, I think it was the American Heart Association, I believe said 2%, so 2 out of every 100 people that present with heart attack symptoms or actually maybe having a heart attack type picture, 2% will have this disorder, Takotsubo cardiomyopathy or catecholamine toxicity. So we have to remember that, yes, it very well could be a heart attack, and this is a very serious disease, and it requires similar treatment depending on how severe it is. But a lot of times, these folks, if they have heart attack symptoms, what are they going to do? They're going to have to go for a coronary angiogram. And these folks sometimes will go in and they'll find that their coronary arteries are completely wide open and patent and beautiful. But the heart muscle abnormality, that's where it's at for the diagnosis. Um, Trying to see what else I wanted to hit on that front. But it's just good to know in your mind the context in which these things might occur, and also the symptoms they might present with, which I think we've hit. It sounds like you had a fairly typical presentation. Now, thankfully, you're young, presumably relatively healthy. When this happens in an older person, it's much more dangerous because they tend to have comorbidities. They tend to have emphysema. They tend to have, if they smoke or whatever, they tend to have coronary artery disease or maybe, an unruptured aortic aneurysm or something, hypertension, diabetes, and it's more problematic. They've got less room to work with when it happens.
And it's
And
really important too, because I just one of the
yeah,
things that I wanted to bring up in regards to that my first experience with a patient that had it was, you know, the physician was very upset with her that she was not keeping her blood sugars under control because as I mentioned, she was a type 2 diabetic. But the problem is like when you're going through something very difficult, a lot of people comfort themselves with food, and that's not great. That's really not a great coping skill. However, it's just a reality, which is something I think a lot of people do when they're depressed, especially when she was going through. I mean, she lost a
mhm,
child, so it's just like that was part of
right.
why she was so distressed, and um, he was mad at her because she couldn't keep her sugars low enough, and like we were having like pretty close like back to back follow ups for this because again burnout's a thing, but when you lose compassion for people in this industry, that's kind of when you maybe need to think about stepping back because that person still deserves
Yeah.
your time, your attention, your compassion. And so to me it was just like until we can get this depression and this heart condition in combination with like how just clinically depressed she was under control, I don't see how we control the diabetes without that first. So it's like you have to look at somebody like they're a
Oh,
puzzle.
exactly.
Yeah, it's like it's a puzzle piece. It's
Yeah.
not like you can't just go through like this bullet point list and everything gets better, unfortunately.
Yeah. And that's what makes medicine so hard, especially in cases like this, is that it's multifactorial for many people. And you have to figure out what's the best way to address the many factors which are causing them not to be able to, get over this or not get over this, but to heal from this, I guess, to get back on track. And it's different for everyone.
Mm-hmm.
I think it becomes more complex the more comorbidities you have.
Yes, and healing
Um,
is not
I
linear,
wanted to,
unfortunately.
yeah, I wanted to talk a little bit about the actual, since I am a forensic pathologist and you are an autopsy assistant, I wanted to talk about the actual death stuff here, um, because that's what we do, right? What I found was, and this is from the American Heart Association, is that the death rate, now they did a study of 200,000 people. So N equals 200,000, that's a really good study. And what they found was the death rate was 6.5%. So six or seven people out of 100,000 who get this will perish. So this is a very serious disease that you have to, and I almost wonder is it that the mortality rate may be a little higher because it's not recognized well? It does make me wonder about
I
that.
think
But
so.
also, yeah, and I will say also, it is more likely if you are a male that you will die. Twice as likely if you are a male. A
That makes a
male that
lot of
gets
sense to
this,
me, unfortunately.
11% die. Yeah. So, thankfully, if you're a female, you have a little better odds. If you're a male, you have twice, it's twice as bad. And then complications, I think is where you get into this. Probably there are more people dying from the complications than we know, because the complications are congestive heart failure, atrial fibrillation, actual like shock, so cardiogenic shock, and stroke. And so I'm just imagining myself as an autopsy pathologist getting a person, maybe not getting a very accurate or good history, and then doing an autopsy and saying, oh, look, they have a stroke. They died of a stroke. And yet, what was the causative agent? What was the thing that started the ball rolling? Well, it may have been some horrible event, the death of this person's wife, or the death of a child, or maybe they lost their career of 40 years right before retirement. And the cause of death might be more related to this disease. So I think it's under recognized, and I think we've established that. And hopefully people will start thinking about it if they watch this. But yeah, I think that is interesting. But I'll tell you what else is interesting about this one. We talk about trauma and we talk about sadness and despair, but this disease can actually occur with excitement, happy news. This is one thing I found, and I gotta say, it makes sense, but I didn't really know this, that there have been people have this from like winning the lottery or from having some great personal success
That
happen to
sucks
them.
so much.
They will actually develop this. Yeah, that sucks a lot because at that point, it's not a broken heart syndrome, it's like a happy heart syndrome. And so you might be wondering, well, what's the mechanism? It's the same. Your adrenal glands go nuts when you get excited. They pour out a bunch of catecholamines, your heart gets stunned. And so, I know I've been excited about a few things in my life, but now I'm like, gosh, should I not get so excited? I don't want to give myself Takotsubo cardiomyopathy. But yeah, so I found that to be very interesting that happiness can actually cause this. Now, I do want to say my personal experience is I have never diagnosed this at autopsy. And the reason why, there's a couple of reasons. Number one, I need to have a history that suggests this. And a lot of times we do get good histories and other times not so good histories. Number two, no, actually three things. Number two is it's rare. It's not that common. It's not super rare, but it's also not that common. So I'm only autopsying people, with sudden death. So there might be an older person who maybe doesn't get sent for autopsy because, they're 88 and they have multiple medical conditions. But the biggest one for me is that if you are looking for that octopus trap shape, that is on ultrasound. That is clinical. That is a clinical thing. When it comes to me at autopsy, after somebody has died, the muscle will relax.
Mm-hmm.
And the odds of me seeing that at autopsy, I think, would be very low. Now, of course, I'm always going to look for it. Just in the back of my mind, I have to think of it. But I have never made this diagnosis at autopsy. And I did try to run through in my mind, have I had a case that fits this, where a person died after a person that they knew died? And I've had sisters, I've had mothers and daughters and things like that die within months of each other, but I could never connect it.
Right.
I will say going forward, I will entertain that, but I've never been able to connect it so far. Have you ever seen one, Jessie?
Not
When you're doing autopsies?
because, like you said, the clinical presentation is not going to look the same once the body's deceased, and that ventricle is no longer moving. So, the only thing I can think of when it comes to, and this is like my favorite thing I think about pathology, and I'm not trying to denigrate anybody else, like ER doctors. I'm not trying to denigrate you. I've worked with some amazing, ER people. And it's kind of hard because I don't even like this comparison a lot sometimes, only because, when you're in the ER, you're expected to find the thing that's going to kill this person, treat it, send them on their way until they can see their primary care physician, and then move on to the next person so you can do the same thing for them. That's almost asking for miracles in a way. So I want to acknowledge that first.
Yeah.
However, when we talk about things like burnout, and you talk about things like just not listening maybe in a way that you probably should be, there's things that will present to you that you may misread that may result in somebody's death. And I have seen that. I've seen Janeway lesions mistaken for like track marks or something to do with addiction, when it was like, yes, there was addiction in her past, but she was clean and she was septic because of an infected heart valve that had broken off and was circulating. But one of the things that I love about pathology and autopsy, whether it's forensic, whether it's anatomical, you view the entire person from head to toe, and you don't necessarily separate things the way that you would if you were like, a specialist and you're kind of only focusing on a body system. I think sometimes what that has done is it's separated things that are connected. And so you have to look at a person as 100% connected. You can't isolate things. This might be contributing to this, much like, kind of like that vicious circle of like high blood pressure and kidney disease. What came first, the chicken or the egg kind of a thing. So it's just, yeah,
exactly. Yeah. And you did make a great point. That is my favorite thing about pathology too, is, and I always say this, that the autopsy is the best physical exam you'll ever have.
It is the center of medicine,
say that over and
over. I don't care what anyone says.
Yeah. And I will say one thing that is underrated about pathology is, particularly autopsy pathology, is you actually do have to be good at physiology. When you talk about internal medicine and ER doctors and folks like that, and anesthesiologists, they are supreme at physiology. I was not a big fan of physiology when I was in medical school. Not a big fan. But as I've gone through and I've had to put these cases together, looking at medical records and then the body, I am 10 times better at physiology as a forensic pathologist than I was when I was seeing living patients. So, if you're out there listening and you're interested in going into forensics or autopsy pathology and you're worried, oh, I'm not going to use my clinical brain, you will use it. Trust me, I use it every day.
Yeah. And actually, I did autopsy and clinical pathology before I did work with live patients. I actually did my externship because I went into medical assisting to kind of get out of the minimum wage bracket so I could continue to fund my medical education. But
Right.
I externed at a pathology lab rather than just going to work at a clinic. So I did autopsy, all of that, and then forensic autopsy before I ever worked with live patients. And I have to tell you,
Hmm.
like, the reason why a lot of physicians that I've worked with think that I'm different than other medical assistants that I've worked with is solely because of that. Like, it's because of that
Yeah.
pathology education and my, like, I got very in-depth look at diseases and all kinds of that kind of thing. So that's what the only thing that sets me apart from other people is the pathology education.
I wish we had more of it in medical school.
Yes.
I went 4 years and we didn't see a single autopsy. I didn't have to do a
Which
single
is
one.
crazy.
And which is absolutely insane because in the old days, that's how medical students learned. 70, 80 years ago, they had to go do autopsies on the wards and stuff. And they learned a ton. They were really good doctors, but they understood the pathology. And now I have caught an attitude from some medical students that it's not important. I'm going to be a vascular surgeon. I don't need to know it, blah, blah, blah. But I've also had medical students come and rotate with me and they say, this is the most incredible experience I've had in my entire medical education. And now I wish I had chosen forensics. But it's always too late. They're like in their fourth year. They've already interviewed for their specialty.
Right.
And it is great. And I always welcome, medical students to come in and they come away from the autopsy really enriched, even if they only see one or two things, just to see the consistency of the brain, to see the diameter of a coronary artery, to see, the psoas muscle, or to see CPR related rib fractures. They get a huge amount out of just seeing one autopsy. And I personally, if I was in control of medical school, I would make every medical student see at least 10 autopsies before the end of their medical education. Now, medical
That
school
just makes sense
administrators
to me.
yeah, medical school administrators don't like that because none of them are autopsy pathologists, and they think it's an old world thing that doesn't have any relevance anymore,
Isn't it
which is
crazy
sad
how they
because,
refer to us?
uh,
Like, you and I were
yeah,
talking about how much we love like Victorian era like forensics and medicine.
oh
Isn't it
gosh,
funny how we're almost
yeah.
seen that way whether we like it or not? Like,
Oh, believe me. Every time I meet somebody new, that like it's another physician or something, they're like, "Oh, what's it like chopping up dead bodies all day?" They act like I'm just in there with a chainsaw, like I'm Leatherface or something. And it's a little more precise and a little more involved than that. We could do a whole episode just on that. We should do an episode on like the history of forensic autopsy and medical education. And then we could talk about the history, and then we could talk about how it kind of doesn't exist anymore. Um,
I
but
would
anyway,
love that.
that's
And I would also like to talk
and that
about,
actually, yeah,
sorry, I would also like to talk about like the Burke and Hare murders because, like, those were two
yeah,
serial
for sure.
killers who were trying to actually they were, rather than just grave robbing, they were actually killing people and then
Yeah,
giving them to medical students. But it is a fascinating time in history that I'm just utterly in love and obsessed
it
with.
really is. And believe me, we will come back to that, but the way they were killing people was so interesting. I won't
Yes,
get into it. I'm not gonna ruin it for the listener.
we'll tease it.
We're gonna go over that. We will go over that at some point. Jesse and I we will have our meeting. We're gonna bring in the coffee and the donuts, and we'll have our meeting that we do every week. So anyways, I think that we're good. I think that we're probably ready to maybe wrap it up.
Yeah.
And I will say that just to kind of close, overall, Takotsubo cardiomyopathy, a stunning of the heart muscle, should be a temporary condition. Mortality rate 6 to 11%. Heart attack-like symptoms. So think about it if for yourself, think about it for a loved one, and if you're a healthcare worker, think about it for your patient.
And then
I
just,
think that, yeah,
sorry, just baseline.
I
If you're
mean,
having heart issues, just go to the doctor. That's just be safe. Yeah,
Exactly. I
just be
mean,
safe.
you don't want to ignore that sort of thing. So if you have any questions or comments about this podcast, you can message us. You can write Jesse. You can go to the Knife After Death Instagram page, and you can see the images. She's going to put those images up at some point soon, I think. And you can comment. You can let us know what you think. And if we said anything wrong, got anything wrong, or you just want to add something, we'll address it in the next episode. Which, by the way, we don't have the release for the next episode yet. Keep in mind, we're going to get to that. We wanted to do the Ellen Greenberg thing, and I'm not going to go on a big tangent here, but I got so many messages on, please do this. I'm begging you. People picketing outside my house, please do this. And we will get to it, but I have to research it a little better before we jump into it.
Yeah, it's
So
just it
hopefully before
requires
the end of
speaking on a case like that again with as many messages as he is getting, with as many, like, if you know that you're one of the people that's been sending these messages, it speaking on cases like this is kind of daunting because like we're doing it publicly. And but we definitely don't want to be those people that just, I mean, you guys all know, I call them true crime perverts. They're the ones that just talk ad nauseum about things that they truly have no expertise on. And part of being intelligent is knowing when to shut up. And so that's why we haven't done it yet.
well,
Like,
and for me, being an actual forensic pathologist, medical examiner in this
yes.
field, when I talk about somebody else's case, it can be a little bit you can ruffle the feathers a little bit of people because it's almost like I'm commenting on the work of somebody else without having been there. And you can do that if you're in court, but in a venue like this, it can be seen as disrespectful or speaking out of turn. So I have to be careful on how I approach it. And that's why Jesse and I are going to figure out the best way to talk about that case. We may do it in the context of watching the documentary and commenting specifically on things in the documentary rather than, hey, I have the report here and I want
That's
to
a good
talk about what
idea.
the pathologist did or didn't. You know what I mean?
I
So
think
we'll
that
get
that's a
around to
great
that, but
idea.
just everybody be patient.
Yeah.
Everybody be patient. Jesse and I, we can't leave the house. People mob us in the street. People inundate us with requests. It's like being a rock star. So we don't have we just need a little time. You don't want to get somebody upset that's big in the field. But so I try to watch what I say, but I will speak honestly about it. I'm not we'll get around to it.
Right.
But with that being said, I hope you guys enjoyed this episode. Um, Please hit up our socials, the YouTube, if you want to see us, if you want to physically see us talk about these things. I think it's a good thing to watch, to share, to tell people about. And it's more of an academic approach to a true crime type podcast. But we also touch here on medicine, pathology, art, history. We're going to hit everything. Oh, and if you have questions in terms of episodes you'd like to hear about or see, send that, and we can fast track something if we think it's really good. We're really flexible over here in the headquarters of the empire, and we will enjoy to hear from you all. Jesse, do you have anything else tonight?
Just when you, as I mentioned in the beginning about the free stickers, just message me your address with your email. And like I said, the first 10 are going to be the ones that get the free sticker. So just put your address in there and then I'll send you a free sticker.
Isn't she nice? That's my producer right there. You got to trust the producer. Also, yeah, well, that brings up a point. People have been begging us about merch, and we're working on it, okay? We're working on
Stickers
it.
are
Just calm
first,
down.
everything else is later.
Yeah, stickers are easy, but then when you get into mugs and t-shirts and stuff, it gets a little more. All right, so we'll see you next time. We're going to have a good episode, hopefully same time next week. And tell your friends and family. And we're trying to make this thing a little bit more routine and a little bit more reliable than I've been over the last few years. With that said, good night.